Hi, this is Dr. Sam Mann and our podcast, Beyond Conventional Medical Thinking. Tonight, we have a guest who's a very prominent ophthalmologist in New York, Dr. Robert Cykiert. He is a board certified ophthalmologist in Manhattan. He is a clinical associate professor of ophthalmology at the NYU Grossman School of Medicine. He is fellowship trained in corneal and external diseases of the eyes, sees general ophthalmology patients, and specializes in cataract surgery, dry eyes, and glaucoma. So we are going to talk about those um, entities. Um, I've invited Dr. Cykiert to discuss the cause and management of common eye conditions and to offer advice based on his considerable knowledge and based also on the lessons he's learned from decades of clinical experience. Welcome, Robert. How are you?
Okay, great. Thanks for inviting me, Sam. This is very exciting, and I think you're off to a great, exciting start. This is going to be a great program because it's going to reveal to patients lots of things that they may not know and are difficult to find on the internet and even on AI, and sometimes they don't hear it from their doctors. So you're going to be revealing some very important things for
Right.
patients.
And sometimes even AI isn't right.
AI often hallucinates still, so you have to be very, very careful.
Yeah, I think that's the right word. So why don't we start with something that's very, very common is cataracts. And so many of us are going to have to deal with that. And when we talk about cataracts, evolution did a great job protecting our health, but evolution didn't have concerns for us after the age of 50 or 60. We are on our own. And obviously, cataracts are mainly in older people. So we're going to talk about cataracts. And Robert, what percentage of people over the age of 70 or 80 do you think end up with cataracts that need treatment?
Well, that's a great question. A large percentage of the population in that age group develops cataracts, probably 40 to 50%. However, not all of them need surgery or any type of intervention. I think it's first important to explain what a cataract is. So we
Mhm.
are born with a lens inside our eyeball. That lens sits right behind the pupil. You can't really see it if you look in the mirror because it's transparent. And that lens focuses the light that comes into your eyes. What happens in our first few decades is that lens is crystal clear and focuses the light sharply that comes into the eye. But something happens in your 60s, 70s, and 80s, and that lens starts turning cloudy and hazy. It becomes sort of amber or yellowish colored instead of being crystal clear. And as a result, it can't focus the light that comes into your eye. So that's what a cataract is. Many of my patients think cataracts are something dangerous like cancer or some growth inside their eye. It's not, it's just their clear lens that they were born with starts becoming cloudy. We don't know exactly what the mechanism is for that, but it's just aging changes like the rest of our body undergoes aging changes. So does the lens of the eye. And there's also good evidence that ultraviolet light from the sun causes damage to this lens over decades of time and eventually causes it to be cloudy. So it's a good idea to wear ultraviolet blocking glasses starting at a pretty early age, and maybe that will delay or eliminate cataract formation. Now, initially, in the first phase of cataract formation, patients don't notice much, but after a while, the cataracts can change the prescription of their eyes. So the glasses they've worn for years or sometimes decades all of a sudden don't work. And that's because the optical properties of the lens change as it becomes a cataract. And often, all that's needed is just an adjustment in the eyeglass prescription. Now, once a cataract starts developing, that change in the prescription of the eye can occur every few years, or in some patients, it can occur every 6 months or so. So sometimes they need uh, new glasses or a new prescription every half year or a year or so, which gets kind of frustrating for patients. But the question is, when do you need surgery for cataract? The answer is when your vision is reduced and the doctor can no longer give you an updated eyeglass prescription that makes your vision good. By good, meaning it is good enough for you to function and do your normal daily activities and work and drive and use your computer and so on. If the cataract gets to that point where you can't see well and the doctor says, I can't come up with any glasses that make your vision better, then at that point, surgery is needed. So, not everybody who has a cataract needs surgery. It's only the people who have decreased vision, who can't get better glasses, and who need the better vision either for their work. Let's say if you're an accountant working on a computer, or if you're a surgeon doing surgery, you need to see better. Or if you're a driver, you need to see at least 20/40 vision in one of your eyes. And that's the point to have surgery. So I see many patients in my practice who come in and tell me they want me to do their cataract surgery, but when I examine them, I find, I can just change the prescription of your glasses and significantly improve your vision. So you really don't need surgery yet. You might eventually need it in a year or two or five or whatever. But right now,
One thing I wonder also, aside from the visual acuity, which is the criterion that makes sense, to what extent is night vision, for example, in terms of driving and glaring headlights, aside
right.
from visual acuity, how big a problem is that and is it dangerous for people to drive at night if they have that, even if their vision during the day is reasonable?
Right. So many patients complain that they have trouble driving at night because they have glare and halos from car headlights and from street lights. Especially now with the LED headlights that cars have,
Mhm.
patients get more glare and halos and difficulties. So what I tell the patient is the difficulty you're having with night driving just kind of annoying, or do you feel it's dangerous? In other words, you can't see the lines on the road, you can't see the signs to decide where the exit is. And sometimes they say, nah, it's just annoying, but I can get by. It's not a problem. I don't feel like I'm going to get into an accident. I can see the cars, I can see pedestrians. If they tell me it's just an annoyance, then I tell them, you don't really need surgery. If they tell me, wow, I can't see the signs, and the other day I almost didn't see a pedestrian, then that's a different story. Then they need surgery. So the patient has to tell me what they're experiencing. I can't be in their shoes. If they feel it's dangerous for them to drive, that's an indication to do surgery. If it's just kind of annoying, but they can still get by and drive and do all their work,
Mhm.
then surgery can be postponed, or sometimes they don't need it at all. Now, technically, the law says you have to have at least 20/40 vision to drive. That's in New York and just about every other state. But what happens with glare, if you have a cataract and if you get these halos and glare from car headlights and street lights, your vision can drop from 20/40 to 2100 or 2200 just while you're exposed to that glare. And then you can't really see where you're going. You can't see the cars ahead of you. So we have ways in our exam to check for glare and how that affects the visual acuity on the eye chart. And sometimes I find a patient may see 20/40 on the eye chart, but when I do the glare testing, their vision drops radically. And at that point, if they tell me I'm not comfortable driving anymore, then surgery becomes an option.
So you can actually assess that in your office, the
Yes,
night. Yeah, interesting.
yeah, you can evaluate that and
Yeah.
determine. But the most important thing is the patient's symptoms and how they're coping with the glare issue. And you get all kinds of answers from different patients.
Right. Is there a risk to this surgery?
Well, cataract surgery is one of the safest operations out there. There are about 4 million of them done in the USA every year. In fact, it's probably the highest volume of any surgery done in the USA because we have many senior citizens. People are living longer. As they live longer, many of them wind up needing cataract surgery. So I do surgery on people in their 70s, 80s, and even 90s without a problem. In fact, I may have the world's record for the oldest patient ever. A patient was 106 years old and had cataracts, and she was totally blind in both eyes from severe cataracts. So I did surgery on one of her eyes, and she lived for another year or two after that, amazingly.
Hmm.
But the surgery has an extremely high success rate. There's a 98 to 99% success rate with cataract surgery. So the risk is very low, but with any surgery, there's always a tiny risk. We don't have any surgeries that are zero risk or totally risk free. The
And
other nice thing, yeah, go ahead.
the surgery is good for how long before you may run into the problem again, or is it good for as long as they're going to live?
The surgery is good for as long as you live. Once a cataract is removed, we put a lens implant inside the eye because remember, the cataract is the lens of the eye that became cloudy. So when we remove that lens, I have to put a new lens inside the eye. So we put a plastic lens inside the eye. And that lens lasts, as one of my clever patients said, you mean that lens lasts longer than I do? And I go, exactly. That lens lasts forever. Now, sometimes some patients, about 20% of patients, develop a cloudy membrane behind the lens, and we can clear that up with about a 2 or 3 minute laser procedure in the office. But once you've had cataract surgery, the cataract doesn't come back. Now, as you age, you may develop other eye problems such as glaucoma, macular degeneration, other things, but those are unrelated to the cataract and the cataract surgery. So it's
Here's
highly successful and it lasts forever.
right. And here's a question. I don't know if you can answer it, but maybe there's data. What percentage of people who have impaired vision from cataracts, for whatever reason, are just not getting surgery? Either they don't see the eye doctor or they just assume they're going blind. Is there much of a population that really should have the surgery that isn't aware that they should have it?
That's an interesting question because at least once a month, I'll see a patient who comes in complaining of severe blurry vision, and I examine them, and they have severe cataracts, and their vision is just horrible. Sometimes they can't even read the giant E on the eye chart, and I'm amazed they were able to make it to the office. So I examine them, and their eyes are normal, other than severe cataracts. And I tell them, you have severe cataracts, you really need to have surgery, and they tell me they're scared, they're afraid to do it, and they just go from doctor to doctor, and every surgeon tells them the same thing, and they're just frightened to do it, and they continue getting worse and worse. Many of them eventually have a fall and an injury because they can't see well, they can't navigate in the street, they trip on a little crack in the sidewalk, and they wind up with broken hips and other complications. That's pretty rare. I would say that's like 1 out of 1,000. But there are patients out there who have a phobia about cataract surgery, even though the surgery is painless the way it's done these days. It's under local anesthesia. It
Mm.
takes about 15 minutes to do it. It's outpatient surgery. You go home about an hour after it's done, and you can resume 99% of your normal activities the next day. And the vision takes several days, rarely to several weeks to fully recover, but you can do all your normal activities pretty much the next day.
But if you were a klutz before the surgery, you're going to be a klutz afterward.
Yeah, we don't make Olympic athletes out of you by doing your
Yeah.
cataract surgery, but you will see better. You'll be able to enjoy life better, and there are many studies showing that senior citizens who have cataract surgery for significant cataracts have reduced risk of falls and injuries. And there's data to show that it's beneficial for your brain. It seems to also help patients who have possibly early dementia. And it's been known that if you increase the sensory input to the brain functions better. So I've had many patients that I personally have witnessed who seem to be having early dementia issues. And after I do their cataract surgery, they're more alive, they're happier, they interact better with their families and friends, and it's a real huge benefit.
Yeah. No, we go into medicine to help people, and
Right.
Boy, it helps so many. Let's move on to another very, very common problem, dry eyes.
Right. We're seeing more and more dry eyes for some reason. Nobody knows why, but several decades ago, dry eyes were kind of limited to mostly women who were postmenopausal in their 60s, 70s, and 80s. We thought that it was due to reduction of estrogen and possibly other hormones. And what happens is they didn't produce sufficient tear fluid. There's a little gland that sits right above your eyeball on the outer part of the eye, right under the bone there, right under your eyebrow. It's called the lacrimal gland. The lacrimal gland is constantly producing tear fluid, and every time you blink, that tear fluid spreads over your eye and keeps your eye moist and lubricated. I give patients the analogy, it's like the wiper fluid in your car. You press the button and it squirts on your windshield. And then your windshield wipers are like your eyelids. Every time you blink, you're spreading this tear fluid over your eye. Well, for some reason, as people get older, especially women, they produce less tear fluid. So the surface of the eye dries out. And what that causes is a irritation. It often feels like there's sand or grit or dirt or an eyelash in your eye. It makes your eyes red often. It makes them more difficult to open in the morning. They feel dry and scratchy and irritated. And it can also cause blurry vision and glare and other symptoms like that. Over the past few decades, we've seen it more and more in older men. And now, in the last 10 or 15 years, I'm seeing it in younger patients as well, in their 20s and 30s and 40s. There are thoughts that it might be due to air pollution, environmental changes, but recently we think there's a huge cause, and that is a large use of computers and phones. Studies show that when you're on a computer or a phone, you blink less. Your blink rate diminishes by about a half. And what's happening is your eyes stay more open and your tear fluid evaporates out into the atmosphere and it dries your eyes out. This is much more common in the winter months when the humidity in the air is low and you have the heat on at home, at work, in your car, and it blows in your face, and that dries things out even more. So we're seeing more and more patients who have dry eye. It's estimated that about 5% of the population or more has dry eye at this point.
Right, but the dry eyes, when you talk about the slower blink rate during computer use, does that carry over to the rest of the day when you're not at the computer, or how does that uh,
It
have a long-term effect?
Yeah, it does carry over because what happens once the cornea, the surface of the eye, dries out, it takes roughly 12 to 24 hours for the cells on the surface of the cornea to recover from the dryness. You're actually losing microscopic cells on the surface of the cornea called the epithelial cells of the cornea. Now, these cells fortunately regenerate pretty quickly, but it can take them 12 or 24 hours to regenerate. So if you're on a computer from 8 in the morning till 2 in the afternoon nonstop, your corneas have dried out, and then they remain dry the rest of the day till you go to sleep, and then they lubricate some more. But the next day, the same cycle occurs. And now people are at work on their computer all day, and then they get home, and what are they doing? They're on their phone or they're on their computer again, like we are now. And when you're on a computer, you just blink less. So it's a big problem. The last data I've seen is a few $1 billion a year are spent on treatment for dry eye condition. It's a huge problem.
Right. And speaking of the treatment, what would be the treatments that you would recommend?
Right. So it depends on the severity of the dryness. I can examine a patient with my equipment, which gives me a high magnification view of the cornea of the eye. And I put in a special solution in the eye, and it kind of lights up the cornea and tells me how much dryness there is. So, with very mild dryness and mild symptoms, patients can buy lubricant drops over the counter in the drugstore. If you go to a drugstore, there's usually a whole aisle of lubricant drops. The drugstores dedicate a lot of shelf space to lubricant drops, which tells you that this is a big problem and a lot of people are buying it. The thing I want to caution patients about is that there are two types of lubricant drops. There's what's called preserved lubricant drops, and then there are preservative-free lubricant drops. You're always better off buying preservative-free lubricant drops. It says that on the label. And those are better because the preservatives in some of these drops are actually toxic to the surface of the eye. So if you put in more than 2 or 3 or 4 drops a day, you're actually going to get an irritation of the cornea. So the first treatment is just using preservative-free lubricant drops, maybe 3 or 4 times a day. Have them sit by your desk by the computer, and every few hours you can put in a drop, and that lubricates the eye. In more severe cases, the over-the-counter lubricant drops are not sufficient. There are several prescription eye drops that are now available for treating this condition. What these drops do is they cause your lacrimal gland, the gland that produces tear fluid, to produce more tear fluid. And we also know that people who have dry eye have an inflammation of the surface of the eye. So these drops, commonly known as Cequa, C-E-Q-A-A, Q-U-A, or Restasis, R-E-S-T-A-S-I-S, or Xidra, X-I-I-D-R-A, or a new one called Tryptyr, T-R-Y-P-T-Y-R. These drops reduce inflammation on the surface of the eye, and they also cause your lacrimal gland to produce extra tear fluid. So it's like putting extra windshield wiper in your car wiper tank so that you don't run out of wiper fluid when you press that button. So
Right.
these drops are usually taken in conjunction with the lubricant drops.
Well, so you take both.
Yeah, in severe cases, you take both. So you would take the prescription eye drops, such as Cequa, twice a day, once in the morning, once at night. And then during the day, you would take the preservative-free lubricant drops 3 or 4 times a day. Now, some patients have even more severe dry eye, and the prescription drops and the lubricant drops are helpful, and they feel better, and they see better, and they're more comfortable, but they still have dryness. What I do then is I put these tiny microscopic plugs into the tear duct. There's a tear duct on the inner part of your eyelids. It's microscopic, but I can see it with my equipment. And I very gently put a little plug into that tear duct. What that does is it causes the fluid in the eye, the tear fluid, to stay longer in the eye, because normally when you blink, the tear fluid spreads over your cornea, but then the tear fluid goes down the tear duct to the back of your nose. If you put a plug into the tear duct, the fluid stays in your eye. So think of it as your kitchen sink. If you put a plug in the drain and turn on the faucet, the sink is going to fill up with fluid. Similarly, when we put these plugs in, which takes about 2 minutes to do, there's no pain or discomfort. They last about 4 or 5 months. They're dissolvable usually. And these maintain extra fluid in your eye. And I would say 90 to 95% of patients with a combination of plugs and the lubricant drops, preservative-free lubricant drops, and one of the prescription eye drops, such as Cequa, will have resolution of their dry eye problem. But I remind these patients that this, unfortunately, is an ongoing sort of a chronic condition. We don't have a cure for it. We have ways to manage it. So it's similar to high blood pressure. You have to take your pills every day. Or if you have elevated cholesterol, you have to take that every day. Or if you have diabetes, you need to take your medication every day. So dry eye tends to be a long-term type of problem, but we have excellent ways to manage it these days.
Question. In dealing with the problem of overnight, you go a long time, um, would one use the liquid eye drops, or would one use some sort of an ointment for nighttime? Is that preferred, or go either way?
Yeah, great question. You must be an ophthalmologist on the side to know that. That's great. So I have patients who tell me that they wake up in the morning and their eyes are so dry that they can barely open their eyes. They have to kind of pry their eyelids open. And what that tells me is their eyes are drying out at night. And in those patients, I prescribe a lubricant ointment. and that's also available over the counter. The two common ones are Refresh PM eye ointment or Systane, Systane eye ointment. And what they do at night is they pull down their lower lid, and in the mirror, they squirt this ointment on the inside of their eyelid, and then they blink. When they blink, the cornea gets covered with this ointment, and it keeps the eye moist so that when they wake up in the morning, they're much more comfortable. Now, the ointment does blur your vision for a while. It's kind of Vaseline in nature. So you don't want to put it in and then try to read a book or your phone or watch TV because things are blurry. So you do that last thing before you shut the lights and hit the pillow. But the ointment dissolves overnight. So by the time morning comes, you're not blurry and your dryness is much improved. So that's another way we can treat that.
Right. I heard also there's a sodium chloride ointment. Is that better, worse, or different?
Yeah, there is what's called a hypertonic 5% sodium chloride eye ointment, sometimes known as Muro eye ointment. That's reserved for people with other corneal diseases like recurrent corneal erosions or patients with corneal epithelial basement membrane dystrophy. That's another condition. That ointment is very effective if you have other corneal pathology. But for dry eyes, it doesn't add anything to the regimen beyond the lubricant ointment.
Right. And one last question. I've heard of the exercise of massaging the eyes as a way to uh, produce, not to produce, but to expel more fluid. Is there any value to massaging the eyelids?
Not really. That won't produce extra tear fluid. The lacrimal gland again sits under the bone in the outer part of the eye, right under your eyebrow. So
Mhm.
massaging your eyelid does not have any effect on that gland. That gland is under the bone, and the
And no
gland
effect on no effect on the tear duct.
no effect on the tear duct or on the lacrimal gland or on dryness. It doesn't help at all.
Yeah. Well, thank you. That was really a helpful
Yeah,
overview. It's such a common problem.
it is.
We have a little time left, so we can talk about glaucoma. And now we're not going to cover every tiny detail of it, but what is glaucoma?
Yeah, so very important. Approximately 4 to 5% of the population above age 60 has glaucoma. And glaucoma is typically an increased pressure inside the eye. The eyeball has fluid inside it that's constantly circulating. And in some patients, for some reason, this fluid accumulates inside the eye and the pressure builds up inside the eye because this fluid can't escape. This increase in pressure damages the optic nerve. The optic nerve is the nerve that connects your eye to your brain. And if glaucoma isn't treated and your pressure is high long enough, and if the pressure is high enough, it will damage the optic nerve and it will cause permanent severe loss of vision. It doesn't happen overnight. It happens slowly, gradually over several years. The problem with glaucoma is most patients don't recognize early vision loss because it's very gradual. By the time patients come in complaining their vision is reduced, they want new glasses, unfortunately, they've lost a lot of vision. Their optic nerve is damaged, and there's no way to reverse that. So, the best advice I can give is if you're 60 or above, have your eyes examined at least annually and have your pressure checked and your optic nerve looked at. Because if we catch glaucoma early, we can treat it with eye drops usually and prevent vision loss. We have very effective treatment for glaucoma, but you need to come in to get it checked. The increased pressure in the eye causes no symptoms. So it's kind of like high blood pressure. Patients with high blood pressure have no symptoms until, they get a stroke or a heart attack or some other severe complications. So the blood pressure doesn't cause an increased eye pressure. They're unrelated, but increased eye pressure can cause damage. And the most common type of glaucoma that I just talked about is called open angle glaucoma. There are other types that are more rare, but the common type that affects 5% of the population over age 60, open angle glaucoma, you need to get that checked annually. And if your pressure is elevated, then you need to be treated with eye drops. We now also have excellent laser treatments for people who can't take eye drops or don't want to take eye drops or have side effects from the eye drops. So we have excellent ways to treat this and manage this. But again, this is a sort of a long-term chronic condition and requires maintenance treatment with eye drops. It's not something you can treat for a week and then it disappears and goes away. The people at high risk of this are people who have family history of glaucoma, it's very important to get that checked and monitored.
Right. And then finally, in our remaining few minutes, macular degeneration. I think most people have heard the terms wet and dry macular degeneration. What are
Right.
they?
Yeah, so macular degeneration is a condition where the retina in the back of the eye begins to degenerate or deteriorate. We don't know exactly what causes that. There is a familial or genetic tendency to it. It's also more common in cigarette smokers. Cigarettes are bad for your whole body and your eyes. And what it does is it causes a loss of the central vision, which is the vision you need to read or to drive or watch TV. And the two types are dry macular degeneration, which is a slow, gradual deterioration of the retina. We don't have any good treatment for that, but there are vitamins called AREDS2 vitamins, AREDS2. The most popular brand is called Preserve Vision. It's advertised on TV all the time. And it's been shown that these vitamins, AREDS2 vitamins, reduce the risk of progression in about 20% of patients. So if we see early dry macular degeneration, I put patients on these vitamins and it reduces the risk of this progressing and causing loss of vision. The wet form of macular degeneration is less common. What happens there is you have the same degeneration, but for some reason, the blood vessels in the retina start to leak fluid, and sometimes they can actually burst and cause bleeding in the back of the eye. This can be treated, but the treatment requires injecting various drugs inside the eye. It sounds horrible, but it actually isn't that bad. It's somewhat uncomfortable, but it's been shown for many, many years that these injections can prevent progression of wet macular degeneration and also preserve vision, actually improve the vision. So if you have a leaking retinal blood vessel that causes a reduction of vision, if you get this injection in the eye, the leaking blood vessel seals itself and the retina actually recovers and the vision improves. And again, anybody over 60 should have their eyes checked at least annually to see if they have the dry or the wet form of macular degeneration. In some patients, the dry goes for years and then for some reason converts to the wet form. And the only way the doctor is going to know that is if you come in for your annual exam. It's the leading cause of irreversible loss of vision in the senior citizen population. It's a big problem. Millions of people in the USA have this, and as we live longer, it's more and more common.
And preventable. And then
It
finally,
is partially preventable, right? And it is treatable.
yeah. And in our last couple of minutes, just very briefly, we all know about diabetic retinopathy.
Right.
And any couple of pointers about it that you would offer?
Yeah, if you have diabetes, whether it's the type 2 diabetes or type 1, you need to have an eye exam at least once a year, regardless of your age, by your ophthalmologist, because we can pick up what's called diabetic retinopathy. This is disease of the retina in the back of the eye caused by elevated blood sugars. And if we catch it early, we can treat it with various methods. If it's severe, again, we can inject certain drugs into the eye, which can reverse it or prevent it. In some cases, we use laser treatment to treat this. The problem with diabetes and elevated blood sugar is that it damages the blood vessels in the retina. And it also damages blood vessels everywhere in the body, the heart, the brain, the kidneys. Except in the retina, we can see it. We can actually see the retina, so we can see the damaged blood vessels. These blood vessels leak fluid, and many of them rupture and break, and you get bleeding inside the eye. If it's caught early enough, all this can be prevented, and loss of vision can be prevented. So it's really critical. If you have diabetes, you should be monitoring your A1C blood test. Many of my diabetic patients have no idea what that is, and that's a problem with doctors not educating their patients. Every diabetic should know what their A1C is. It's like knowing what your blood pressure is, kind of, or your weight. And studies show that if your A1C is 7 or below, it's unlikely that you'll have severe eye disease from diabetes. If it's above 7 for long periods of time, you're likely going to develop retina problems and all the things I mentioned. So you need to get your A1C down, and you need to also see your ophthalmologist annually, whether you have symptoms or not, because if we can pick it up before you have symptoms, that's the best thing. By the way, long-term elevated blood sugars also increase the risk of cataract formation and cause a more rapid progression of cataracts. So that's another reason to keep your blood sugars low and keep your A1C below 7. Closer to 6 would be ideal.
Right. Well, that was a terrific summary of a number of such common and important conditions that need attention and need caution. And that was just great. You covered so much territory in there. And I want to thank you. And I think the viewers will also very much appreciate the guidance that your suggestions offer. And thank you so much.
Thanks very much for inviting me. I'm looking forward to watching the episode as well. And you're doing an awesome job. Educating people in the public and patients is critically important. And want to thank you for doing that.